네 이어폰은 소리 아무것도 안 들려. 아무 말도 안 하고 있다고? 들어왔다는데 소리가 안 들려 이어폰에. Hello?
Hello, we are waiting you for the opening remark, Dr. Chair.
Okay, good morning everyone. Welcome to 22nd TCTAP 2017. I'm Dong-un Choi from Yonsei University Severance Cardiovascular Hospital. On behalf of the board members, I'd like to thank you all distinguished faculties and attendees here to join the TCTAP meeting this year. This year, TCTAP has been offering a variety of sessions from 8 live case demonstrations to featured lectures and case presentations, providing attendees with mastered insight and global perspectives on treatment of PAD and aorta. I hope you all enjoy this year's TCTAP and also your stay in Seoul. We're going to start the live case demonstrations. Thank you.
Thank you, Dr. Chair. I would all the panelists to come up to the podium, please.
Good morning. My name is Mark Burkett, and with my co-moderator, Dr. An, we are going to get started with the live case. It looks like we're ready for the presentation, and so if we could have the live case presenters go ahead and start the presentation, the panelists and moderators and I will make comments. Good morning.
Good morning.
Good morning, how are you?
We are doing fine. We have a panel ready to go. Do you have a case for us this morning?
Yes. Good morning. We prepared, actually we prepared a SFA case, but case was changed. So, my name is Jae-Hwan Lee from Chungnam National University Hospital, and Dr. Chol-Min and Dr. Hae-Won Jung from Severance Hospital. Chol-Min represent the first case.
Yes, we prepare first a very severe total occlusion of superficial femoral artery, but the patient had some personal problems, so we very immediately changed it to the below knee cases. So actually, he is a 52-year-old man with admissions with light leg pain and right great toe wound for about 40 days. And then he had a past medical history of previously the PCI at the LAD and RCA, and then some left had some wound. So he performed the left below knee intervention in this year February, and then he had a history of MCA infarctions and then diabetes and hypertension, and he had also chronic kidney disease. And next slide. So CT scans in the previously before the left intervention, so very diffuse lesions at that time. So the first was left side was more poor, so we performed the left side first, and right side was observations between the time, and then the light gray toe was wound was aggravated. So next slide. Such previously left side interventions. Next slide. So he had actually had a wound in early March, and then the wound was not recovered after some medical treatment. So he reassessed for right side below knee artery. So next slide. So actually ankle brachial index was intact, but the toe brachial index was decreased more than the left side to right side. Done. Next slide. So it's a very actually live cases. So we don't know about the exact vascular anatomy before this morning. So vascular access and the basics of selections and of devices. So we did have a point of discussing. So now, okay.
Actually, this patient, we already taken coronary angiogram and left side lower extremity intervention, but we don't know about the right side below the knee and right side lower extremity angiogram. So we evaluated CT angiogram first, and below the knee artery was a little calcified, and we don't know the exact anatomy of below the knee artery because of calcification, and common femoral and SFA bifurcation is located lower 1/3 of a femoral head. So today we chose antegrade approach. We actually intentionally punctured right common femoral artery a little bit high portion of femoral head.
So that sounds like a very safe approach because it's going to give you a lot more wire manipulation control. And the CT certainly did not give you any definite indication that there was vessel occlusion, but as you pointed out, there's a lot of calcification. So I guess we won't know for sure until you do the injections.
Usually, sometimes we perform a TCPO2 skin perfusion pressure study non-invasively to detect the status of perfusion for the wounded leg. But in this case, we do not have any data for skin perfusion pressure or TCPO2. So,
and it looks like your setup includes a hood or a covering for the patient's head. Is that standard for your antegrade approaches?
Yeah. This integrated approach function was done with a micro function set, and the guide wire seems like go pass through the SFA. Next. But following angiogram revealed this is a deep femoral artery. Next. So we withdraw the microcatheter a little bit high, and we found that SFA osteum like that. Next. So this is a 0.35 inches Telomere wire to navigate the SFA. So this view is a little bit a lateral view. Next one. Then we perform the lower extremity angiogram. So as you can see, there's a distal part of posterior tibial and dorsalis artery. So AT maybe a little bit have some disease, but flow is not so bad. So we introduce 5 French ancestors to the palmatial area. Next. Then we perform the TSA angiogram like this. So plantar artery and dorsalis is intact. Next. This is an anatomic view epicranial, and you can see there is a plantar lobe is also intact, and post metatarsal to digital artery is very good. So the flow is not so bad. Next. This is a BTK angiogram. Unfortunately, there is no CTO region. There is no severe reason to demonstrate to you for specific technique.
Yeah, it's surprising when you see the, certainly you look at the contralateral side and what the history was there, and then clearly a lesion of great significance on the great toe. On this side, we would have anticipated that something would have been hiding in that posterior tibial or in the plantar vessels, but this is surprisingly good.
Yeah.
So is your plan at this point to do any intervention or to go to the wound care strategy?
Yes, lateral plantar to pedal plantar to post digital connection is good. So I think intervention is actually not needed for this patient, but there is a tight stenosis of anterior tibial artery, shaft of anterior tibial artery, so we will not do a balloon angioplasty for the anterior tibial artery.
Any comments from the panel?
좀 넣어줄래요?
Dr. Lee, do you really want to have a good outcome of the balloon angioplasty at the mid part of the ATA? Because it's I don't know. What do you see? Because already some correctness from the posterior is very good. So region is I think there's some another region for the If you check the some perfusion pressure, CO2 pressure, CO2 pressure is some pink part. Maybe is do you have some answer to wound healing or not?
로드맵 해줄래요? 선생님, 예, 스마트 컨트롤? 됐어요? 오케이. 선생님, 와이 해주세요. 안 보이네?
나와요.
오케이. 오케이.
Dr. Lee,
Okay.
I'm
Yeah.
Dr. Go from Seoul St. Mary's Hospital. Which wire do you select?
I usually started with regalia. It's a very soft wire. Same with field FC for coronary. So long regalia. And this is not a truly occlusion. And just stenosis can pass the region. 빼줄래요?
May I ask, is there any calcified plaque or something? No?
No. Some moderate calcification, but the region was not totally occluded, so wire is well gone. So this is a balloon, very long balloon, tapered long balloon. Distal diameter is 2.5, proximal is 30, length is 210 amperion. Inflate here.
So Dr. Lee, is your goal here to improve the overall perfusion to the foot in hopes that somehow helps out with the inline flow that the patient's getting through the posterior circulation?
So middle portion is a little resistant, but 저장해 줄래요? So we are very sorry for this is so much simple case. So anyway, this balloon angioplasty will be the first and last treatment for this BTK region.
What size of the balloon?
This is a 2.5 and 3.0 tapered balloon.
Tapered balloon. We, know,
Yeah.
we need a longer balloon in this case.
Yes, because previous angiogram. Because the region is a little bit previous angiogram. Region is a little bit long,
Okay.
and so we chose long balloon.
You prefer tapered balloon.
Yes,
In your
prefer
daily
to
practice.
use.
In your daily practice.
Yes, I prefer to use a tapered balloon because BTK region usually long CTO, and there is a size discrepancy for the proximal and distal part. So I frequently use 2.5, 3.0 for usual size. Sometimes for the 2.0, 2.5 tapered balloon. So I usually apply 3 minutes for balloon angioplasty, and sometimes a little bit more time needed for recoil, prevent recoil.
And what is your strategy if you have recoil that won't go away? In other words, if you've done the balloon angioplasty, it looks exactly the same after 5 minutes, what do
Yeah.
you go to then?
So actually, there is no specific tool to improve recoil, just more balloon angioplasty. Sometimes we need a nitroglycerin injection. Sometimes there seems to be a thrombus aspiration, but usually balloon angioplasty is the main stem to.
So you would not use a bailout coronary stent?
No.
How about the use of a scoring balloon?
So we don't have a scoring balloon for the BTK region in Korea.
Oh, really?
So
In Japan, maybe many operators choose some scoring balloon at first.
yeah. So do you have experience for the scoring balloon for the BTK region? Is it quite different for the simple balloon angioplasty?
I think so.
Definitely.
I think what's easy for us to overlook now that we have so many good long balloons is how revolutionary long balloons have been in this application. When we started doing these and we had to use 2-centimeter balloons and work up and down the artery, all we were doing was shifting plaque, and the results were not very good. I think things have gotten significantly better just by using long balloons.
오케이, 찍을게요. 왼쪽. 오케이, 레더를 비워서 찍을게요.
So it looks like a moderate amount of calcification, but not dense.
오케이, 여기서 찍을게요. Picture here. Sub.
It's very nice.
distal. Okay. We may need additional balloon angioplasty for the distal ATA. 와이어 잡으세요. 와이어 잡아요.
So I have a question for some panels. So do you think that this lesion was a truly atherosclerotic or it's a neuropathic? Actually, he had a diabetes, but it's not a bad control. So, what's your opinions? And then what can I do for some medically for this patient?
저쪽으로 완전히 돌릴래요? 완전히? 더? 오케이, 더? 오케이. 플로로세이.
I think this patient really highlights how important it is that CLI is treated as a team. This is one where you want to do all that you can from an endovascular standpoint, but you clearly need good wound care on the other end. There are a few reports that indicate that cilostazol improves wound healing, although that's pretty scant data.
어떡하지? 별로 할 말이 없어서.
It seemed on the last angiogram that you had a column of contrast. Looked like it was in the posterior tibial. Did you notice that? I think it was on fluoro after your that last. So this run looked like there was significant improvement in the anterior tibial, and it seemed to me on fluoro that there was contrast still in the posterior tibial, which I couldn't explain. It may show up later.
Do you think we need balloon angioplasty for the posterior tibial artery?
On my initial look, I did not think that you did. That's why I'm wondering about why the runoff seemed to be slow. I wonder if we're missing something, because the patient has tissue loss. The artery looked open, but if the contrast is hanging up, I think we need an explanation.
Actually, at the beginning, we have given nitroglycerin, so we will give a little bit more nitroglycerin at this time. And anyway, I don't think that we need to dilate the posterior tibial artery, even though the flow is a little bit, looks like a little bit slow, but balloon angioplasty can make a region worse, so I don't like to do deflate.
I think that's exactly right. Right now, it looks like you have flow, even if the artery's not pretty. It still has flow, and you could definitely get a dissection and then be in a worse position.
튜브 다시 이쪽으로 돌려줄래요? 오케이, 잠깐만요. 오케이, for now. 오케이. 오케이, picture again. 한번 찍읍시다. picture. 컨트라스트 맞았죠? 네. 왼쪽. So, ATA, it looks better. BTK 인적으로.
And the flow is pretty good in the posterior tibial also.
Yeah.
And now it's cleared, so I'm not
옆에 좀
sure.
펴줄래요?
I'm not sure what I was seeing
그냥
in the last
그대로
one.
놔둬요. 그대로 놔둬요. 옆에 좀 펴줄래요? 오케이. 왼쪽으로.
We'll probably do this angio, and then I think the next room is ready, so we may switch over there.
오케이.
Yeah,
Looks
you've got
fine.
an intact loop,
Yeah.
good
Okay.
perfusion.
This procedure has completed. I'm sorry, actually.
I think this is an instructive case because a lot of times we go into angiography expecting one thing and we see something else. You have a very nice result in the anterior circulation now. Hopefully with some good wound care, this patient will heal up and have a good prognosis. So yeah, I think this was a valuable teaching case. Thank you.
Thank you.
Thank you. Dr. Che.
Hello.
Hello.
Good morning, everyone.
Morning.
I'd like to introduce my team. I'm Dong Choi, and my next is
I'm Sang Shin from Ilsan Hospital.
yeah, and third is Chung-gi Kim, our faculty, and Dr. Shin introduce our case, please.
Okay, I present the case. 37-year-old male patient have suffered the intermediate claudication. He have suffered acute myocardial infarction about 4 months ago, and he had long duration of diabetes, more than 10 years, and he is not so good compliance. And he also have a dyslipidemia. Next. As you see, the ankle brachial index is 0.54 and 5.9 in both legs. Next. And CT angiography shows diffuse long total occlusion of left leg, and there is quite few calcification, but the lumen is pretty small. Next. So this patient is very young age, but high risk patient. So we plan to do the IVUS and atherectomy first. So we are going to do that. Thank you.
Okay, let me show the first angio case. Angio, please. Okay, this is angio with 7 French sheaths. As you can see, the SFA quite small and big development of the deep femoral artery. And I think the next segment is quite not long, but next, yeah. next 안 넘어갔죠? 4번. 4번으로 안 넘어갔어 이거. Next. Yeah. And this is the second image of the distal SFA. As you can see, total occlusion and tandem lesion. But the distal SFA is quite small. So I think this patient is 39 years old, relatively very young patient, but history of CAD, acute coronary syndrome, and over 10 years diabetes mellitus, and very poor controlled. So I think I want to check his artery intraluminally. So next. So yeah, this is V18 wire with backup the CXI catheter, and I checked the IVUS. So I will show you IVUS. IVUS image 좀 보여주세요.
So this is a bare
you see
V18 wire
IVUS
that you started with, is that right?
Pardon?
You started with a V18 wire
Yes,
with
V18
no support
wire.
catheter?
Yes, support catheter CXI.
CXI,
by Cook.
okay.
Yes. And after that, I exchanged the O14 wire and IVUS. IVUS 보내줘야지. 왜? 그럼 화면이라도 보여줘, IVUS. Okay. IVUS run, and I will show you IVUS image. Okay.
Okay.
Could you see IVUS image? Yeah, this is distal, from the distal pulpitular artery and the distal SFA. As you can see, distal artery is about 4 centimeter, quite small, and a large amount of atheroma, and a slight negative remodeling, and yeah, still quite small artery, and large amount of atheroma. Typical IVUS image of diabetes mellitus patient, and this is a common femoral artery. One more, repeat, please.
So very
Yeah,
small
this
diameter
is-
throughout.
Yes, yes.
We
could
never
you
saw the
suggest,
distal circulation. Are the infrapopliteal vessels patent?
Yeah, I didn't check, but CT showed that the distal, below the pulpitular artery is intact.
Okay.
But I didn't check the by angio. So I think the artery is very small and a large amount of atheroma. So after IVUS, I tried to remove the atheroma by jet stream catheter. Yeah, next jet stream. Yeah, jet stream 나오는 거. Yeah. So I tried jet stream. This is 2.4 millimeter jet stream catheter. 2.1? Yeah, 2.1. Yeah, because the artery is very small, so maximum size is 2.4, but I used the 2.1 millimeter jet stream.
And it looks like you do this over a bare wire, not with embolic protection. Is that correct?
Yes.
Okay.
Actually, I did not embolic protection, but 맨 파이널 보여주세요. I did 2 times atherectomy with the jet stream, but I did not pass the distal 2 centimeter. This is angio. You can see the distal re-entry was about 38. And I did not pass the distal 2 centimeter because I worry about distal embolization. So
you stopped short of the re-entry point.
yes. So I'll show you one more atherectomy and distal pass.
Dr. Che,
Okay.
I'm Pilgimin.
Yes.
The wire position is somewhat eccentric along the SFA, so is it safe or is it okay to perform chest atherectomy in this eccentric
Yeah.
atheroma?
But I checked the IBIS and the wire is interluminal, so usually atheroma is eccentric, so I cannot change my wire is a central position, so I'll do my best, but I cannot change my wire position in the just central. Stop. Yeah. Actually, the jet stream usually advance very, very slowly, but I already 2 times passed the proximal part, so I do quite fast past the proximal part, and I'll show you this re-entry part, the pass. Okay. Stop. Stop. Move. 화면 좀. Okay. Activation. Okay.
Sounds like it's going very easy. I don't hear any RPM drop.
자, 아까랑 똑같은 이미지. 조금만 위에서 시작할게. 오케이. 액티베이션. 이거랑 똑같이 이미지. 자, 액티베이션. And this point is the re-entry point, so I advanced the jet stream catheter quite slowly, very slowly, and advanced 1 centimeter and legs, and
Are you getting
back
good return
with
from the
legs
jet stream?
system, and okay, stop, and activation. Stop. Next. During the retrieval of catheter, you should push the legs button to suction the atheroma and the debris. Okay. Activation. Next. So one more time. Okay.
Now you're well into the patent
Okay.
but diseased
Right.
segment of the artery. Still small diameter. So then you're rexing back, making multiple cuts antegrade. It looks like all of these have been with blades down. Is that correct?
뺍시다.
다 뺄까요?
Dr. Choi? Dr.
Yes.
Choi and Dr. Ko.
Okay, thank you.
In Korea, we can use the atherectomy device, two kind of device, directional atherectomy such as Jetstream and
Yes.
directional atherectomy such as Silbok or Tobok, and
Right.
rotational atherectomy such as Jetstream. Which atherectomy device do you prefer?
Yeah. If the patient, I usually select by the patient angio, but if patient angio show the high calcification and eccentric atheroma, I usually prefer turbo. But this kind of a very long diffuse atherosclerosis disease, I prefer Jetstream. But Jetstream recently available in Korea, so I did not have a lot of experience, but my selection criteria is that. Yeah. I'll show you the angio for subtraction. sub이죠. Okay. Okay. Actually, the proximal part are connected from the proximal, and about the distal SFA and near the pulpitary artery, still large amount of thrombosis. So I think we're going to pass one or two times.
Some of that distal narrowing may be due to spasm. I think this is a great device, but there's no question that the vibratory component induces spasm. And sometimes that responds very nicely to nitroglycerin and a balloon inflation.
보이죠? 옆으로. 오브레이.
I think you can make a case for all of the different atherectomy devices. One of the nice things about this is you can advance it blindly to some degree. You don't have to be on fluoro 100% of the time while you're advancing it. You don't have to worry about any directionality, and you have the option of blades up and blades down. So there are a number of things that make this a pretty easy thing to use. You can kind of see, too, with this device, when it's in a diseased segment of vessel like it is right now, it doesn't really move back and forth very much, but when you pop through an atheroma into a normal segment of vessel, then you see it kind of vibrate or oscillate, and it just kind of bangs from one side of the vessel to the other, which I think really produces spasm. And the idea of this device is that it aspirates while it cuts. So theoretically, you don't need to use an embolic protection device. I think in our practice, we use an embolic protection device each time we use it, usually a NAV6. so that the
위에서부터
basket is
NG
independent
할게요.
from the
빼고.
wire.
맨 위에 보여줘.
That does add about $1,600 to the case, though.
자. 자, 우리 NG 한번 따라가면서 찍어볼게요. 오케이.
I think one of the big questions is whether this is how most of
NTG
SFA
같은 게 있나?
disease will be treated in the future. If we have good clinical trials that show efficacy of plaque removal followed by drug-eluting treatment, then it may really be worth the added expense and trouble of going through this. Right now, we're doing this on the assumption that it's helpful, but we're still short on good data.
앵글 좀.
This device can be applied in the BTK
바로
region.
보여주죠.
This, this atherectomy device can
Okay.
be applied in the BTK, below the knee regions can be.
This is, in our practice, we use this almost exclusively above the knee. It can be used below the knee, but we use it almost, this is kind of the typical application
자,
in our lab.
서브트랙션 엔조
popliteal.
디지털부터. 됐어.
와이어 방향이 좀 바뀐 것 같은데.
응?
와이어 디지털 와이어 방향이 바뀐 것
아니야. 서브트랙 앵글 줘서 그렇잖아. 자, 서브트랙션. 예, 갑니다. 본론 4짜리 하나 주세요.
지금 들어가 있는 게.
오케이. 오케이. 됐어. 본론 사이 긴 거.
Dr. Che,
오케이.
can you show
Yeah.
us the IVC imaging after this time?
I think the distal artery is quite small, so I'd like first the balloon, and after that I will show. 오케이. 아이비스 좀 보여주세요. 아이비스 좀. 아이비스 보고 싶어 하시니까 아이비스 좀 보여주죠.
Yeah, I'm not at all surprised by the appearance of
이거
the
좀
distal
보여주세요.
vessel.
오버레이 좀 띄워주세요. 와이어 디지털 TV 절로 들어갔다 그지? 오케이. 네, 자 아이비스 들어갑니다.
와이어
움직이지 마.
와이어 좀 잡았죠. 아니 안 떨어지게.
됐고. 자, okay. This is IVS from the pulpitular artery. Yeah. 라이브로 나오는 있는 거지? 오케이. 레코딩. 자, 갑니다. This is a pulpitular artery and P1 segment. Yeah, slightly, still large amount of atheroma because that jet stream is only 2.1, and
I think there's still a lot of atheroma, which you would
Yes.
expect in a 3 or 4 millimeter vessel, but I think clearly you also have a channel. I think there's no doubt that you've made a significant change in the appearance of that vessel.
so I think one option is the bigger size jet stream, or another one option is balloon angioplasty. So, what do you think about that?
Well, I think you could also do blades up, and I think balloon angioplasty will also show you significant improvement as well.
잠깐. Okay, so I have only 10 minutes, so I think we're gonna balloon angioplasty with a 4 millimeter balloon. 자, 발론 껴주세요. 네.
I like how you're trying to preserve every option that you have, because this is a guy who's under 40 years of age.
Yes.
So staying in the true lumen, debulking, trying to avoid stenting if you can.
Right. Yeah, I
'cause this won't
totally
be as-
agree with your opinion. This patient is relatively quite young, so I think the leave nothing behind the strategy in this patient is very good option, and 아까 거 맨 마지막 거 한번 잠깐
This will
보실래요?
not be his last procedure.
맨 마지막 거. 오케이. 거의 P1까지 가야 되네. 오케이. 잠깐만. 확실하게 테스트 해봐야 돼. 와이어가 제대로 들어갔는지. 들어갔죠? 오케이. 얼른. 천천히 2. This is 4.0 and 150. 2. 환자분한테 아프신지 여쭤보세요 한번.
It'll be interesting to see what pressure that lesion yields at, because you would anticipate after running the jet stream down there, it would have a low yield pressure.
4. Okay, save. Usually after atherectomy, I usually put the balloon with very low pressure, not high pressure, because especially this patient, I do not want to make a big dissection, and flow-limiting dissection means put the stent. But I don't want to put the stent in this relatively quite young patient, so I usually balloon angioplasty is very slowly and gently and low pressure and prolonged, usually over 3 minutes. So sometimes 5 minutes or more.
And not only is it a young patient, he's a young patient with a very small diameter fem-pop segment, so you'd be stuck with a small stent and then high chance of restenosis and very limited options afterwards.
Yes. Yeah. And our hospital analyzed our data and showed the stent extend beyond the P2 or P3 level, make a big problem, restenosis or stent fracture, and so a lot of problems. So I do not want to put the stent beyond the P1 segment. And usually, I want to put the stent only in the SFA. So I think your suggestion is quite good.
I think that's exactly right. That one of the things that I think we sometimes think is that the artery flexes at the same point where the anatomic joint is, which is incorrect. The artery is actually showing more flexion right about where that air bubble is in the balloon. And so stenting down at that area is where the stents are the most likely to flex and be subject to fatigue.
Yeah. 이거 조금만 더 올려달라고 그래. 마이크가 거의 안 들린다. 조금만 더 올려주세요.
Dr. T, is this
Yes.
conventional balloon?
Yes.
Why do you select conventional balloon, not drug-coated balloon?
Yeah. Actually, the final angio showed the still residual stenosis, and I've also showed a large amount of atheroma. So I want to select the conventional balloon first, and after that, if the still the residual stenosis or some angio showed some problem, I applied that area only drug-coated balloon. So yeah, so I use the conventional balloon first, next the balloon, and after that I'll check the angio and I applied. I think the artery is quite long, and quite small, so yeah, balloon. But DCB is also quite good result, but I think this patient DCB is also I don't want to apply the whole artery for DCB, so I try first. This is only 2 atmosphere and the balloon fully dilated. This is a 4 millimeter balloon. So I think after that I checked the angio and I will apply the DCB.
Could you explain to us who are not from Korea that the economics of drug-coated balloons in Korea? In other words,
Yeah.
if you use
Actually,
multiple balloons, does that cost go to the hospital or the patient?
Yeah, our government reimbursed the 2 drug-coated balloon for SFA and 1 drug-coated balloon for pulmonary artery. So in this patient, we can use 3 drug-coated balloon for reimburse. But after that, patient pay.
So after those 3, then the additional
Yes.
charge is passed on to the
Yes.
patient?
Yes.
Okay.
Dr. Che, I understand you choose to proceed to ballooning due to time limit, but if you don't want to put the stent, it would be better to remove as much seroma as possible.
Right.
In this case.
Yeah, so if I have enough time, I tried the jet stream with actually I passed only 2.1 millimeter, not the extend, not used to the wing. So if I have enough time, I tried one or 2 times jet stream with extended the wing, and I think that if that angio showed a more nice result, but this is a time limit, so I think I will show you next. Yeah. And this is 150 millimeter balloon, so the total length is almost over 300 millimeter, right?
Yeah, this
balloon.
vessel is really heavily diseased all the way from the origin all the way
Right.
through the popliteal.
Yes, from the popliteal to 4, 5. Okay.
So it looks
And,
like all of these areas yielded at a pretty low pressure.
Yes. Only.
One of the discussions I've always found
only
interesting is people talk about atherectomy of various sorts being beneficial because it reduces barotrauma. And when you look back at the original literature about atherectomy, where that started, it's based on no data at all. There's really no information that indicates that inflating a vessel at a high pressure is harmful. It is a problem if you can't inflate a vessel, if you don't get the lesion yielding, but there's really no data that I can find that high pressure hurts a vessel.
I think that right now is the era of the drug applied to the vessel, drug-coated balloon and drug-eluting stent, etc. So this time, I think the vessel preparation before drug use is very important. So if the vessel has a heavy calcification, I usually use the atherectomy device, and also this kind of very large amount of atheroma and long diffuse region. I also prefer the atherectomy first, and after that, I choose the balloon or stent. So I think the vessel preparation is very, very important, and our concept is slightly changed.
I think that
Okay.
certainly makes sense. Certainly the article that Finelli published a few years back showed that restenosis was related to calcification
Okay.
percentage. And if we can somehow prepare the vessel and get better exposure to paclitaxel or whatever agent we use in the future, it makes sense that that would reduce restenosis.
오케이. 그만 빼. 자, 따라가면서 한번 찍어볼게요. 그럼 서버로 2번 찍을게. 자, 오케이. This is a angio with after 4 millimeter balloon. 어머. 그냥 움직이지 마세요. 다리를 움직이시면 안 돼요. 네, 편안히 계세요. 편안히. 움직이시면 우리가 사진을 못 찍어서 빨리 안 끝나요. 이제 거의 끝나가요. Okay. Some dissection at the ostium of SFA, but I think the flow is quite good. And 아니 미드도 한번 찍어줘야지. Okay. 자, 움직이지 마시고. Yeah. And also you can see the dissection, and but not flow limiting. And I'll check the final, the distal SFA and the popliteal artery. 움직이지 마세요. What do you think about that, the result?
So when you look at the entire vessel, it's dramatically better. I agree that the inflow dissection is not flow limiting. You're going to end up with drug-eluting something here. I think I'd favor, in this region that we're looking at right now, a 5 millimeter drug-coated balloon. Worst case scenario, you get a dissection and you have to stent. But I think that this is enough residual. I'd be a little reluctant to leave this. How about from the other panelists? Would you be inclined to continue to treat or leave it alone?
I want to try the lung barrel inflation again in the distal part of the. Again, lung barrel inflation again for 5 minutes or 10 minutes or something like that. At the low pressure.
At the distal SFA, right?
Yeah, yes. But time, I know time is limited, but you can continue.
Dr. Chet, we have 1 minute left. So what's your plan now?
I think the proximal part and mid part is quite good lumen gain, but the distal SFA, and as you can see, still residual stenosis. So I applied the drug-coated balloon. 메트로닉 드럭-코티드 balloon 있나요? 5짜리. I'd like to apply the drug-coated balloon at the distal SFA, and with 5 millimeter. And after that, I check the angio, and if the distal artery is dilated, I want to finish.
Yeah, what size do you do?
위에 제일 긴 거, 5 millimeter. I think the 5 millimeter drug-coated balloon is enough size. Distal, I've checked the distal artery is over 4, and actually the popliteal artery is quite good. So I think the 5 millimeter is okay. 이게 제일 긴 거 5에
150.
5에 150. Okay. This is a 5 millimeter and 150.
So I am
Thanks.
afraid we're not going to be able to stay with you for the next part, but clearly you've made tremendous progress in this vessel. I think you're going to help this patient a lot. We'll be anxious to hear about the follow-up, but we're going to have to go for now. Thank you very much for an excellent case and a really good discussion.
Okay, thank you very much. Thank you, everyone.